back to another episode of the Rick and Danny Show. Danny, how you feeling today?
Feeling great, Rick. We're doing great at the new Beaches office. Have you been over there yet?
I've not, but you do look more refreshed, vibrant. I don't know if it's just related to the fact that you guys moved, or you trying to do lotion. What's going on?
It's the move, and it's more sunlight coming into that new office.
There
The
you go.
windows,
A little bit closer to the ocean.
A little vitamin D action.
nearer to the ocean, near Florida ceiling windows. Not quite, but almost there.
Cool.
But yeah, it's going great. We've been open now for 2.5 weeks, I think.
Yep.
We're in Neptune Beach, right off of A1A, the west side of A1A. I think the address is 700 North 3rd Street, if I'm not...
703rd Street.
703rd Street. If you put in north, I think it sends you the wrong way. Is that right?
No, I think it sends you the right way.
Okay.
It's technically, that was a whole thing.
Okay.
It's
But 703rd Street. And
Third
it's,
You guys
floor.
sound like you really got your stuff together.
we do.
Okay, all right.
Yeah,
Take your word for it.
Christ.
we're honing it in here. It's called the Atrium Building, and it says that on the front of the building. So
Well,
forever,
I plan on going to the open house.
Open
so
house?
That'll be probably my.
that's next week.
Chance to
Brenna,
see
can
it.
you give us an
Next
update
week,
about
we
that?
are rocking and rolling. It's going to be great. I'm
Okay.
in charge. Don't worry. We got some RSVPs. Got a lot of docs coming. Don't look panicked. You looked a little panicked.
Who's coming?
Because you
Here.
said some RSVPs,
Well,
and then we have a lot of
Well,
docs
we
coming.
have a lot of. Okay, let me clarify. A bunch of our guys are coming.
That's
and
good.
The
That's
other
good.
ones, it's always slow coming in on
Yeah.
RSVPs.
So
Don't
people
worry.
are coming who didn't RSVP, probably.
Probably.
Are you
yes.
basing this
yes.
off the event calendar?
Yes.
Interesting.
Okay.
Okay. Well,
But the open house
You
is going
stop.
to be a great way for people to see the
I
new
don't
office.
see a lot of green. I see some green.
here is my proud.
Rick's always a little
my
negative.
proud
so that's
mom picture
Oh,
of
yes.
Danny.
Yeah.
Day one in his
Oh,
office.
nice. Aw.
I do.
Sweet office.
I do arguably have the best office.
Yeah.
Alicia, Dr. Sugarman gave it up to me because the office across from me is bigger, but it has less windows, and I took the one with more windows.
Yeah, your office looks like the nicest I've ever seen.
Oh, thank you, Rick.
Meanwhile,
Not
the
the-
radiation team is moving to an office with no windows at Fleming. So
Not the
I'm
shoe
going.
box
I'm
these
going.
guys sit in.
Literally
Where
no
Where are you guys
windows.
moving?
I'm going down, and you're going up.
Okay.
I
Well,
think, you know,
no, you're not going down.
I'm moving
You just
down.
need to request
I'm moving
windows.
down in the world. You're moving up in the world.
Do the
Where are you
Medonks
guys-
get
Where are you
windows?
guys moving to?
I don't know. Something about one of the scheduling rooms because they need more room. Brent, I just work here. I don't know.
Me too. Me too, guy.
I think you're important, Rick. More important than you give yourself credit for.
I would
don't feel
agree.
important.
Okay. This
I'm
isn't
more than happy to feel less important.
Well,
This
that's
isn't
not
supposed
gonna
to be a
happen.
overtime about Rick's rants here.
That's not going to happen. You're
This
stuck
is not
on
a
marketing.
rant. This is how I
and
talk in everyday life, Danny. You know me well enough.
You're also stuck on all the other committees that we have you on.
How many committees are you in, Rick?
Too many.
Too many.
Whatever.
Like officially?
Yeah.
Like official committees, marketing.
That's
and-
true.
Oh,
Well,
I'm on way
it's
more
not
than
that many.
what do you want?
Imaging, research,
Okay.
marketing, finance. Gotta be missing
Ooh.
something.
That's a lot of committees.
Unofficially?
Unofficially, I don't know.
Apparel?
Apparel committee, food committee.
Food committee?
There should not be an apparel committee.
Foundation committee, a little bit.
You're trying to add me to that one.
Podcast committee?
The podcast.
Yeah,
which
the
is
podcast
a
is
pretty big
huge.
time commitment.
Huge.
So yeah,
Huge.
I'd say I like to pull my weight around here. I'd like to think.
You work hard. You work hard.
He does.
Get some of our
We
other
appreciate-
partners. to
Give the
step
guy
up.
some windows. Come on, man. But yeah, the Beaches office is
Killing it.
doing great. Doing great.
It's beautiful. It's really,
I'm excited
really
to see
nice.
it. Sounds amazing.
Decorated fabulously. The girls did a great job.
Who
setting
decorated
up.
it?
I think just Shar and the nurses.
Shar, your office manager.
Yeah.
Cool.
Really nice job. Really pretty.
Yeah, so
the
open house
signs
next
inside
week.
look great.
We just need the sign outside. That's what we're
Yeah.
waiting on.
I don't know. I heard whoever
Something
did
to
the
help
signs
direct
was
people.
Not very good.
Huh?
Huh?
What?
What?
What did you say?
Sorry, I couldn't hear you over.
We have flags
said what you were
outside.
doing. Flags.
Yeah.
Nice.
I don't really want to get into the sign part of my
And
life. at
is
this
the
moment.
imaging still at Baptist or is it at the new center?
Well, so
TBD.
yeah, so it's set up to be at the new center, but not. It hasn't started yet, but it
So
will
there's like
soon.
something with the parking lot they got.
Yeah, they had to put down new concrete to make it sturdy enough to hold our
Got it.
truck
that'll
there.
that'll be coming soon.
Yeah, I think probably in the next few months, I would guess. hopefully in the next month or two.
And the pet truck's going to go there?
The pet truck's coming. There's whispers of maybe MRI coming out there. So
Yeah, we
stay
need
tuned.
hopefully get another MRI here soon.
Mm-hmm.
Would be nice.
Yeah. So, but we'll definitely have PET scan, CT capability out there very
That's
soon.
exciting.
So
Cool.
Awesome.
convenient that patients can get their imaging done right on site. Don't
Yep.
have to go anywhere else.
That's awesome.
Yep. And then I'm seeing patients full time there, Monday through Friday. Dr. Sugarman's there Tuesday through Friday, and then Dr. Kadali's there full time, sort of. I think Thursdays she goes to a different location, but she's 4 days a week at least at the beach. So, yep, we're excited to continue seeing our patients there, a great group of patients, and servicing the community there.
Very good. Proud of you guys. Congratulations. That's awesome.
Big time. You big,
Big
time now, Denny.
time.
Big
time.
windows.
Although a lot of
Big
patients
man
are
in the big
confused.
windows.
So, what about probably like 5 buildings down from us, there's a brand new, like, all glass business
Oh, really?
building of
Oh,
some
yeah.
sort. I think they have some real estate offices, other business offices, and quite a few patients have gone there thinking that they'll find us. And we're not that building. We're the atrium building.
It says atrium.
Says atrium.
There's flags. We're
Um,
going to have signs.
But I agree with them. That building's very
Is there
nice.
nothing that's going to be on A1A? That's obvious.
So we're
Yeah.
waiting. We had to wait for permits.
There's a sign on
There's a monument sign out
right in front.
That's there's got to be something.
Yeah.
Right?
Yes.
And then on the building, we're going to have 1 or 2 logos. 2 logos.
It's in production now.
Mm-hmm.
I have signature. We're rolling.
Great. We're moving on. All right, I got one article here. This is not an official Rick's Rant article. It is a article that we didn't get to talk about from our ASCO update. I thought it was worthy of our mentioning because a lot of patients come to us talking about different cellular therapies these are mainly for blood cancers like multiple myeloma, B-cell lymphomas, leukemias. So ASCO this year, they reported on a few different CAR T-cell trials. The one I'm talking about right now is one that was published in the New England Journal of Medicine after was discussed at ASCO this year. And I think it was most noteworthy because it's a phase 3 trial, and it's in patients with multiple myeloma that's considered refractory to lenalidomide. Lenalidomide is one of the main treatments that we give for multiple myeloma. Most people get exposed to that drug in the beginning of their treatment. And I thought this trial was worth discussing because more patients are being seen at local centers for CAR T-cell therapy. This particular CAR T-cell therapy is called Cilta-cel, is the short way of saying it.
Sounds fancy.
And it's targeting BCMA. So CAR T-cell therapy is a way that you can engineer your own T cells in a laboratory setting to be infused back into your body to fight your cancer, and in this case, multiple myeloma. So BCMA is a protein on myeloma cells. It's also on other B cells in your body, but mainly the goal is to target BCMA on myeloma cells and have your T cells attack the myeloma. And what they reported here was phase 3 trial in patients who had progressed on lenalidomide, and they randomized people to receive the BCMA CAR T-cell therapy, the Cilta-cel, or physician's choice of effective standard of care. All patients needed at least one prior line of therapy, including lenalidomide, up to 3 lines of therapy. And they had 419 patients, and progression-free survival, and again, that's something we'll talk about later, but progression-free survival at 12 months in the CAR T-cell arm was 75.9% compared to 48.6% in the standard of care arm, or the standard care arm, which is physician's choice of multiple myeloma treatment. Overall response rate was very high at 84.6%, and 73% of that 84% were complete responses. And 60% of those with complete response, or 60% of patients had absence of minimal residual disease. And what that means is that they do either next generation sequencing or they do flow cytometry to look for basically one cancer cell in 100,000 or 1 out of 1,000,000 cells. So it's really looking for that that microscopic cancer cell that's floating around, and they usually do a blood test or a bone marrow biopsy to confirm that. So anytime you have absence of minimal residual disease, meaning you're not detecting any minute cancer cell in the body, that usually means that you have longer term remissions. And so this trial is early, in reporting because they really only had a median follow-up of 15 months, which isn't that long. But I mean, compared to standard of care therapy, you have patients staying in remission much longer. You have about 3/4 of patients after a year of therapy who were not progressing, compared to less than half were without progression in the other arm. So I think in my practice, I'm referring out a lot for CAR T cell therapy in different lines of therapy. I mean, I think if you have a patient who undergoes stem cell transplant for myeloma and then progresses, consideration of sending them for CAR T cells. There's a lot of trials out there too for CAR T cells. So, for example, at Moffitt in Tampa, they have some trials for myeloma CAR T cells. I think locally Mayo does, but I actually prefer to use Moffitt because they seem to have a larger group that's dedicated to cellular therapies like this one, and I think they just have a more robust team to take care of patients.
Where would this is just my ignorance, where would this fall in, like, or where would it have fallen previously in your line of therapy? Or would this not have really been
I
the
think
line?
this trial kind of shows, and I do not think that it's FDA approved yet for like after one line of therapy,
Right.
which is one of the groups that was included in this trial. But certainly, I think once there is approval, it would be my recommendation that if a patient did or did not have a stem cell transplant and progressed after their first line lenalidomide containing therapy, that you would consider
Go
this.
to that.
Yeah. So more of like a second or third line treatment.
Seems like a pretty big deal relative to
And I mean,
other
the
therapies.
big deal about this too is, compared to other treatments, and I'm not downplaying the workup and the time that you need for treatment with CAR T cells, but this is a one-time treatment. So you get treated and then you're on surveillance basically afterwards. It is a big to-do. You have to collect your T cells. That's done by an apheresis machine, kind of like a dialysis machine. There's a waiting period of about 4 weeks before your T cells are ready to infuse. You do get chemotherapy before the T cells are infused. You're in the hospital up to 2 weeks, and then afterwards you go home, and potentially you could be progression free and off of treatment for 2 to 3 years, and that's off of any treatment. So I think that's the plus of this therapy. The minuses are, of course, there is some toxicity associated with it. There's this condition called cytokine release syndrome, which is when those T cells cause a big immune response and can make you sick, can give you fevers, can give you low blood pressure, can give you neurologic changes, but they've really fine-tuned the way we treat that. So most patients aren't getting sick enough to go to the ICU with cytokine release syndrome. They have good protocols for that, but I think this is kind of where things are heading for not only for myeloma, but for lymphomas. And yeah, we're going to see a lot of patients being referred for it.
Yeah, I think it's cool too. Like you said, it's a one-time thing versus, some of the, I mean, you tell me, but a lot of the myeloma drugs, from an outsider's perspective, some of them seem to be continued like in perpetuity.
Yeah.
People are on it for years or forever, which, has its own. Just logistically is obviously harder on a patient.
Logistically hard. A lot of the regimens, you're coming in every week for some sort of treatment or lab checks. You're oftentimes on steroid,
Right.
like dexamethasone or prednisone for an extended period of time, which we know causes diabetes, can cause bone loss, a variety of issues. So this is potentially sparing those type of treatments, which is good. There is a significant cost associated with this, so I think any kind of holdup by the FDA to approve it for earlier lines is going to be, in my opinion, a financial decision, because we're talking about, hundreds of thousands of dollars to have this done.
Right.
But when you talk about myeloma treatment, which the most expensive myeloma treatments now, like the antibody drugs we give, can be upwards of $15,000 a month. And if they're on it for a couple years, it's going to be equivalent costs. So
Right.
it's, I think we'll leave those decisions up to the people that make them, not us. But yeah, good data. I think we have to think about more about these immunotherapies, these cellular therapies, because that's kind of the wave of the future to limit toxicity.
Well, and then I was, sitting on the research committee, I learned about some things that I had no idea existed, like these bite therapies and other things that are coming down the pipeline. Seems pretty crazy, pretty awesome in a good way.
Yeah. And we even have something open and more trials on the horizon with bispecific trials. So bite therapies where they have these antibodies which are specific to bind to, it could be to myeloma, it could be to a lymphoma cell. And then at the same time, they bind to the immune cells, the T cells, to activate them to fight the cancer. So really cool technology and
Yeah, it
good
seems
for
like
our
it's,
patients.
I mean, I don't, biomechanically it seems to make sense. So hopefully these bear out, because it seems like another new class of agents that could potentially be very effective.
The first one that was out there was for ALL, blinatumomab, which was given as an infusion. It's actually, patients had to be hooked up to a continuous infusion, go home with like a pump, and they had to be monitored closely. And it's still being used, I think, for ALL, but they've refined it to the point where now these type of therapies are given as injections,
Which is
and
awesome.
it's something that can be given in one of our clinics. So,
Right.
Yeah.
Very cool.
So, all right, moving on. All right, we'll talk about.
Should we keep going in this episode, or where are we at?
We'll do quick Rick's rant.
No,
Yeah.
Can we stretch it to a third, or no?
No.
All right, couple quick.
We'll do 3 overtimes, though.
We are.
You'll be fine.
Yeah, a couple of quick comments. I have a couple of Journal Watch articles here. I like the Journal Watch. It gives the updates on all different kinds of trials that are reported, not only in New England Journal, but other journals around, which are pertinent for oncology. So this first one, and this is Rick's rants. We got to hear what Rick thinks. So, do chemoimmunotherapy clinical trial results apply to real-world patients with extensive stage small cell lung cancer? So do you think the trial data for and standard of care for people with small cell lung cancer is giving them chemotherapy with an immunotherapy agent? And so this is an article that came out published in JAMA to say, is the real world outcome of giving these regimens in people with small cell lung cancer the same as clinical trial?
I mean, usually the answer for these questions is no, because the patients on clinical trials are usually, in general, better performance status, better means, better social support, more motivated. You're selecting kind of the best of the best. So you would expect real world outcomes typically to be worse than trial outcomes. I don't know if that's what this study found, but that would be my guess.
Right. So that was the exact point of the article, is saying that those patients who met criteria for the trial in the real world setting did about the same as the trial. Those who did not meet criteria because they were weak or had other, medical issues that made them ineligible did not do as well. And so it kind of reinforces the point that if you're going to discuss clinical trial data with a patient, the trial data is only relevant if they met criteria for the trial.
Right.
So
Reinforces common sense.
yeah. So we'll keep it simple.
I like it.
All right. And then the other cool thing I came across, encouraging results for personalized vaccine plus checkpoint inhibitor in pancreatic cancer.
Interesting.
Have you heard about this?
Very high level. So no, please educate me.
I didn't read the article, Rick, but I read the update.
Okay. Fair enough.
Just the update.
Your honesty is why I love you.
So this was published in Nature, so this is a big deal. Nature is one of the biggest science publications there is.
What Nature, Cell, doesn't get much
the highest
bigger.
impact factor.
Yeah, it doesn't get much bigger than that.
Impact factor. So this was a very small study, not controlled, where 16 patients with pancreatic cancer, and I believe that everyone had advanced pancreatic cancer. So pancreatic cancer that had metastasized or recurred after initial treatment. The patients were all given the opportunity to create a personalized mRNA vaccine against their cancer. So what they did was they sequenced DNA and RNA from each tumor and determined each tumor's neoantigens, which is kind of what the protein expression of the tumor. And they created personalized mRNA vaccines that would cause each patient to make his or her tumor neoantigens in abundance. Wow, that's hard to say. Neoantigens.
It's a good tongue twister for sure.
And then they not only gave the patients their personalized vaccine, but they gave immunotherapy. And the reason to give immunotherapy was to try to enhance that immune response to the vaccine. So they said 8 patients, they measured that T cells, cytotoxic T cells, which is what you would expect to be, produced by the vaccine and the immune response from the immunotherapy. 8 of the patients, they had detectable cytotoxic T cells. And in each of those patients, no evidence of residual cancer was found at 18 months. So early reporting of the trial, but very encouraging results. And then what they did find, though, that in the patients who the vaccine was produced who did not have a T cell response, so they weren't able to measure these cytotoxic T cells, none of those patients had responses. So it looks like a way to determine whether the vaccine's going to be effective or not is
Makes
if
sense.
they actually see that T cell
immune
response.
cell.
Yeah, but I think this is one of the early trials in probably a variety of cancers that we'll be seeing for personalized vaccines. Using that same technology that was done to make the COVID-19 mRNA vaccines to create vaccines against cancer.
Yeah,
and I don't think that the vaccines are going to be effective on their own. I think you're going to need immunotherapy, or you're going to need, back when they were giving IL-2 therapies a lot, you would give something to prime the immune system a little bit. And you're going to need some kind of priming before the vaccine.
Yeah, I mean, I think it's a good, I'm glad people are doing this research, and it makes sense to focus on, extremely deadly tumors like metastatic pancreatic cancer or, glioblastoma, where there's been work done as well in the vaccine space. So I think
there was something reported on glioblastomas too.
I think those are, start with that kind of, deadly, no real options tumors and work your way from there.
Right.
But I think it's promising. Again, logically it makes sense, like it should work.
Mm-hmm.
So, I'm glad there are people doing this kind of research, because it certainly could be a potential another avenue to fight cancer.
Right. Yeah, I think the one takeaway too, though, is just like all these cellular therapies with the, creating sort of immunotherapy treatment, that you need time to create that treatment, right? I didn't see how long it took them to make that vaccine for patients, but I imagine it's
but I would imagine more than, I'd imagine what you do in the future, if this bears out, is you do it at the beginning, right?
Mm-hmm.
Before they get their initial treatment,
right?
And then you have it ready to go if and when they fail or progress.
Right. Yep. Cool stuff, Brenna.
Good stuff, guys.
Thank you all for listening, as always. We kept it a little more educational this go around, so hopefully that didn't put too many people to sleep.
I only fell asleep for 5 minutes, so.
I mean, there's like drool all over.
A little nerdy today, but it was good conversation.
So yeah, so it's fine. But no, hope you guys tune in next time. We appreciate you listening.
See you next time, guys.